We're going to go ahead and get started. I know a few people are still rolling in, but we have a jam-packed agenda today, so I want to hit the ground running here. So first off, welcome to the first meeting of the 2025 Rural HPV Vaccination Learning Community. We're happy to have you here, and thank you for joining and taking time out of your busy schedules. So today's meeting kicks off 10-month journey together. During this call, we'll be setting the stage for preventing HPV cancers in rural communities. And as you may know, 57 million Americans call rural communities home. However, these individuals are much higher risk for HPV-related cancers, and statistics show significantly lower HPV vaccination coverage than individuals living in urban and suburban areas. A one-size-fits-all approach will not work for all of rural America, but many of your communities do embody similar strengths and challenges, which we're going to explore over the next 10 months. We have built out this program using quality improvement as the forefront to explore areas of opportunity and use evidence-based practices to increase HPV vaccination across rural America. We hope that during these sessions, you gain knowledge, hear promising practices, and talk through challenges to increase HPV vaccinations to help protect future generations from HPV-related precancers, symptoms, and cancer in the future. HPV vaccination is cancer prevention, and this program is funded by the CDC. I'm Christina Turpin, and I'm a director for the National HPV Vaccination Roundtable with the American Cancer Society. And I am very lucky to get to kick us off today, but I'm a part of a much larger team here at the American Cancer Society that is helping promote HPV vaccinations every day. And you're going to meet and hear from some of them today, as well as over the next 10 months together. So next slide. This is the roadmap for today's call. I'm in this welcome and logistics, and then we're going to do a quick icebreaker. And then you'll get to hear from our Vice President for Implementation Science, Dr. Ann Gagliotti. Then you'll hear from Athena Porter on her cancer survivor story. And lastly, Dr. Jason Semprini will share some new data on the burden of HPV-associated cancers in rural America. We'll close out with a breakout session just so we all get to know each other and make this journey the next 10 months a little more comfortable. A few reminders here at the end of the slide. All rural HPV vaccination learning community sessions are recorded and posted to public-facing website. So if you do not want your pictures shown, please go off camera. And then we do ask that all participants stay muted until our Q&A, and we do have the chat open for questions and support if you need it. Next slide. So our quick icebreaker here, we want to take a moment to see where everyone is calling in from. So for this component, we want you to use Zoom annotation. You can either use the pen in your toolbar, but I think we found if you scroll over, it should be a little green pen you can click on, and then pick your favorite stamp or write your location on the map where you're located. Just to get, and we'll take a minute to do this. And if you are having problems with that, figuring out the annotate, please put your location in the chat. Looks like it's working though. It's fun to see all your names pop up. I see some familiar names from last year, as well as some new ones. This is exciting. Give you all just one more minute. I should probably annotate for myself. I'm located in Idaho, representing it looks like on this map. All right, I think we'll move to the next slide. Thank you all for putting on here. It's so nice to see where everyone's calling in from. I don't know how to clear that. It's kind of fun. And then before I hand it over to Dr. Ann Gagliotti, we would want to do a quick pre-session poll. and enjoy all the confetti on there. Oh, it just cleared. So let's launch this poll, but we want you to share with us, does your organization routinely recommend the HPV vaccination series? And then to what extent did your organization prioritize adolescent HPV vaccination in 2024? And then prioritization refers to an organization level focus that may or may not include funding, leadership buy-in, or other similar aspects. And I'll give you a minute to answer these. We're about 62% participated. It's pretty good. One more minute. It looks like we have a lot that are showing to number 2, moderate and high priority. That's great to see on here. All right, we'll go ahead and close the poll now. Next slide. So now in the real kickoff to our learning community, I'm happy to introduce Dr. Ann Gagliotti, Vice President of Implementation Science here at the American Cancer Society, to share a wonderful leadership message with all of you.
Thank you so much, Christina. Welcome to the kickoff of the 2025 Rural HPV Vaccination Learning Community. I am Ann Gagliotti. I'm a family physician, and I serve as the VP of Implementation Science here at the American Cancer Society, where our mission is to end cancer as we know it for everyone. We are super excited to have so many of you from around the country join us today. As Christina said, rural communities have a disproportionately high risk for HPV-related cancers and have disproportionately low HPV vaccination rates. So because of this, we know this learning community has the potential to have a positive impact on flipping that script through sharing tailored approaches and evidence-based practices. We do know that rural communities are not a monolith and that the communities you represent are unique. But we are hopeful that this space will catalyze your efforts and allow us to share common challenges and successes to move the needle on HPV vaccination rates in rural communities. We're grateful to our funder, the Centers for Disease Control and Prevention, and I want to acknowledge the amazing work of our teams, especially Ashley Luck and Christina Turpin. We appreciate all of the planning that led up to this launch. And we are so grateful to each of you for bringing your ideas, your engagement, and for the rich contributions I know you will bring to this space. With that, I will turn it over to Christina to introduce our first speaker. Christina, I think you're muted.
Thank you. Thank you, Dr. Gaglione. And I hope everyone can feel the passion and energy in the room in these welcomes as well. I am very excited to now welcome Athena Porter. She is a passionate advocate for cervical cancer awareness and education, a resident of rural southern Iowa. She was diagnosed with stage 1A cervical cancer in January of 2023. After undergoing a successful radical hysterectomy, she was declared cancer-free and has since devoted herself to spreading awareness and advocacy for early detection and prevention. Outside of her advocacy work, Athena enjoys spending quality time with her husband, 2 daughters, and family. She is an avid gardener, enjoys traveling, and cherishes the time spent with her church family. Athena's journey from diagnosis to recovery has ignited a deep commitment to make a difference in the lives of others through her advocacy efforts. And awesome. Welcome, Athena.
Thank you. All right. Well, yes, my name is Athena. I'm from Iowa and a cervical cancer survivor and patient advocate. You can click to the next slide. So here's a picture of me before diagnosis. I was diagnosed when I was 32 years old. And before my diagnosis, my husband and I just were living our wonderful life on our farm. And I have two beautiful little girls. They love our cows, so we had to put them in our family picture. And just living in a state of just bliss with my wonderful life, and was shocked when at 32 I was diagnosed with cancer. Next slide. All right, so I just want to point out here that someone's passionate about something when they're willing to let over 100 people see this selfie of puffiness post-surgery. So this was a picture of me post-surgery, and just wanted to kind of give an example of in-treatment look when you've got puffy face, messy hair, no makeup kind of thing. So that's what I look like on a normal day, but less puffy. So my journey began a very long time ago. I was always a proactive in my health, so I started doing pap tests early on and got abnormal results. Eventually, I had a colposcopy and then a LEEP procedure trying to get rid of that pesky HPV virus. I had never gotten the vaccine when I was young. I was slightly too old when it came out, and it was pretty brand new. After the LEEP procedure, though, I was declared HPV free. I had several normal pap results, so I was very excited for that. And then I dived into having babies and becoming a mother. And because of that busy life, I had delayed screening. Eventually, I got back in and again had abnormal results. And so I was eventually referred to a specialist after it just wouldn't clear. I had a comb biopsy, and then it was confirmed after that I had stage 1A cervical cancer. Since it was caught so early and I was very proactive, it was decided that I would just have a radical hysterectomy. That procedure removed my uterus, my cervix, the top part of my vagina, the fallopian tubes, and then the surrounding tissue as well, just to make sure and test that it didn't spread. Luckily, I was declared cancer-free, margins were clear, and I was very excited to be able to have that successful treatment. And kind of touching there on treatment, I was over an hour away from where I live. I live in a very low income rural setting, and you have to travel over an hour to get to OB gynecology care. Luckily for me, it was caught early, so that was the only treatment I needed. So I didn't have to struggle to find transportation like a lot of people in this rural area do. We don't have public transportation that would take you up there without having to pay a high price for that. And so for a lot of people in this rural setting, it wasn't as easy with the location, the transportation, and just the financial hardship. The people in this area would not have had as easy of access that I do, which I'm fortunate. And I was very fortunate to have as simple as just a radical hysterectomy. And so I was fortunate there. Next slide. I know in this slide it looked normal, so that piece is kind of just funky, but that's okay. So after treatment though, and during, I was surrounded with prayer warriors, and it helped me the most. And I'm just so very thankful for that peace that I had afterwards. There's a lot of resources out there, and I was lucky that at least in my small community, I had so much support within my family and my friends and within my church community as well. Next slide. And cancer can be scary. This is, I know, a group of people that I'm talking to right now that knows very well how scary cancer can be with stories that we've heard. But I was able to find communities like Survivor that helped me know that I was not alone. And it has definitely offered fellowship and resources that have reiterated, I'm not alone in this battle, and that my story matters. And Survivor has been such an amazing group to be a part of, to be able to volunteer and to just continue to grow in my advocacy and in my story, and just to see the great work that it does. Next slide. So diving into this organization, Survivor, which I'm sure a lot of you have heard of, their mission is global, and it has been an amazing one to be a part of. Their mission is to inspire and empower those affected by cervical cancer by educating and motivating them to use their voices for creating awareness and to end stigma, and to influence decision and change and end cervical cancer. And if any of you have ever met Tamika Felder, who's in the center there, she is a powerhouse who is definitely one I look up to when it comes to influencing the decision and change for ending cervical cancer. Next slide. So because of Survivor, I have been empowered for sure to advocate and to tell my story and to spread awareness and education. There's some pictures here of some advocacy that I have been a part of. This past January, I was able to be part of a proclamation for Cervical Cancer Awareness Month here in Iowa, so that was pretty neat. I got to take my girls and my husband there to the Capitol, and we got a photo op, and so it was really neat to show my girls this opportunity, and that even though I had been diagnosed with cancer, you can not let that knock you down, and you continue to push yourself and challenge yourself to do that good work. One other advocacy story that I wanted to tell quick here was a few weeks ago, the medical provider that I work with at the health clinic that I work at here, her and I went to our local high school to discuss HPV virus, the vaccine, and then I got to tell my story, and it went really well. And this week, my provider emailed me and said, one of the students that we talked to came in and got her HPV vaccine because of us coming in and talking to the class about that. And that really just, it lit a fire under both of us. We're emailing, we're like, we need more, we need more. And so we're wanting to continue to go into classes. And now we're looking at schools that are a little farther away that might not have had that story told to them, or HPV told in a way that's like, hey, this is cancer causing, not just some stigmatized STI. And so that was just an amazing advocacy story that we were able to, it's like, it started with one, and now we're just going to keep going up from there. So we're really excited here at the clinic that I work at. Next slide. So just connecting the dots on some of the cervical cancer stats. You can see here in 2025, an estimated 13,360 cases of invasive cervical cancer will be diagnosed in the US, and then about 4,321 will die. And worldwide, cervical cancer is the fourth most frequent cancer in women, with an estimated 660,000 new cases in 2022. And of the estimated 350,000 deaths from cervical cancer in 2022, about 90% of these occur in low and middle income countries. Next slide. So because of those scary stats, we continue to tell our stories and empower others, because we know that we can eliminate cervical cancer. Next slide. So plug for Survivor and the amazing work they do. They also have this patient advocacy training program called Survivor School, and they've been doing it for several years throughout the country. And it has been really neat seeing the women that come from this program. They're paired up with a mentor who's already gone through it. And the women that come from that program, I see that fire and that passion, and they're finding these new ways to advocate, educate, and spread awareness in their communities. And so it's inspired me to find those new ways to tell my story in my own backyard, and to start in those small communities, those rural communities that just need that extra education, or that just different way of telling them why it's important. Next slide. So yeah, kind of like I just said, our stories create change. Whether it's just that one new student who got an HPV vaccine, or convincing somebody to go get their screening, it can create change. All right, next slide. So here's is just kind of a snapshot of a survivor and the wide expanse that it has had as an organization. They've worked with the Cancer Moonshot Initiative, the National Cancer Institute, of course, the American Cancer Society. And so it's been neat to see the collaboration on such a large scale with Survivor. Next slide. And by sharing our stories, we can continue to spread that word. It's been really neat to see, not just here in the States, but globally, how impactful that our stories can be. And so even though, as I sit here, I still have butterflies, and I'm not a huge fan of public speaking, I know how important it is to tell my story and to be able to let people know of just the importance of education and awareness. Next slide. Okay, kind of like I mentioned, empowering others throughout the world has been an amazing thing to see. And within the survivor community, it's been a great thing to connect with people from other countries and seeing what they're doing and being able to spread awareness there. Next slide. And the work we do is for those that we have lost in the past. These women here, they live on because of the stories that we're sharing, and we know that we want to earn that we can end cervical cancer, and seeing their faces just continues to give us that drive and that push and that passion. Next slide. So here is ways to connect with Survivor. If you're interested, they are on all of the platforms. They are all over the place. They are doing such amazing good work. So they are very easy to find on any of the platforms that you need. Next slide. Okay, yep, that was mine. I'm on a lot less platforms. So feel free to email me, or I'm on Instagram or Facebook, though I don't post nearly as much. It's usually me on our little farm, or on the rare occasion I get to go traveling with my husband. So yeah, feel free to connect with me, and I would be happy to chat. So I think that's the end of my slides though.
Great. Thank you,
How'd I
Athena.
do?
You did great. I know you said you're nervous, but it didn't show. You did awesome. And
Good.
thank you so much. That's, why we do this work, is stories like yours. So thanks for, being brave and vulnerable and sharing that with all of us today. Yeah. Now I would like to welcome Dr. Jason Semprini. And Dr. Jason Semprini is an assistant professor of public health at Des Moines University. He earned his PhD in health services and policy from the University of Iowa College of Public Health. And then following his PhD, he completed 1 year of postdoctoral training at the Iowa Cancer Registry. Previously, Dr. Semprini was a Susan G. Komen Cancer Disparities Scholar at the University of Chicago, where he earned his master's in public policy. Dr. Semprini has published his research in high-impact peer-reviewed journals and presented at national conferences. His research uses novel data linkages and causal inference methodologies to evaluate the impact of public health policies and practices on health outcomes and equity. A lifelong Iowan. I don't know if I've ever said that. So as an Idahoan, I'm naturally trying to say Idaho and Iowan. Dr. Semprini is passionate about disseminating policy relevant evidence to address critical health needs and improve the well-being of everyone in his state. Thank you. Welcome, Dr. Semprini.
Thanks a lot. Thanks for the introduction. Athena, that was a great talk. Thanks for sharing your story and continuing to use your story to advance change here in Iowa and beyond. So thank you very much. There we go. All right, perfect. So I'm gonna take a very high level view here and just quick share some recent research, really looking at rural cancer, rural HPV cancer disparities, and kind of what this means beyond 2020. I'm a rural Iowan myself, grew up in Eddyville, Iowa. So happy to show this work that hopefully we can motivate more people to get out and make change like Athena and her peers are doing. So I have no conflicts to report. I'd like to thank St. Jude's Children's Hospital for some research support for this work. So we're going to look beyond, 2020, going to look beyond just looking at HPV-associated cancer incidence. The struggle is real, but we want to also we're seeing some troubling trends in terms of mortality as well, even for people who survive cervical cancer or any HPV-associated cancer. And we're going to look beyond just metro and non-metro comparisons, which is typically what is done because of data availability, but we want to look a little bit more detailed there. So just a quick recap. Athena did a great job talking about cervical cancer. HPV can cause a number of cancers, cervical cancer, other types of genital cancers in both males and females, certain cancers of the anus and rectum, and then oropharyngeal or OPC cancer. And cervical cancer is the highest of all HPV-associated cancers. It is definitely the highest in females, but the OPC cancers, we're seeing that with the largest growth, a very concerning trend. And the rate of this type of cancer is much higher. It's much more common in males than females. So when we look at non-metro and metro incidence, 25 years ago, HPV-associated cancer rates were the same for those two groups. But as you see over time, that gap starts to widen, and it becomes quite wide in the years right before the global pandemic. Now, when we look at what is driving these differences, kind of this divergence between non-metro and metro populations, on the left graph here, we have female HPV-associated cancer incidence. And again, we see a widening gap between non-metro and metro for cervical cancers. Again, it's much more common. Incidence is declining over the last 20, 25 years, but it's declining slower for non-metro populations. So that's driving the gap there. When we look at males on the right side, we see that, again, 25 years ago, the incidence was the same for OPC cancers and all other HPV-associated cancers, but the increase over time has been faster in non-metro males than metro males, leading to the gap we observe today. So those are the two primary cancer sites of concern as we start looking beyond the pandemic. So my research question, it was very, very pointed. How did the burden of HPV-associated cancer change after 2020? So in 2001, the HPV-associated cancer in rural, these micro places where Athena and I grew up, and urban, non-metro places, but are still considered an urban area, and these metro counties, they were all the same 20 years ago. There was no difference. Again, this is before the HPV vaccine was introduced. But 20 years ago, there was no difference in incidence of these types of cancers. Fast forward to just before the pandemic in about 2009, pay attention mostly to the dark black line. That's the rural or these micropolitan communities, the HPV-associated cancer incidence rate in our smallest counties. That trend is rising from 2000, and it's rising pretty similarly with the non-metro urban rate, which is the dashed gray line. You see that the metro rate has been flat. That's that gray dotted line that you see create a large gap. Very good for the communities in the metro, but it's definitely leaving behind those of us in the non-metro areas. But let's jump ahead a little bit. So we see that across the board, the incidence declined. Now, that isn't to say that the pandemic reduced the burden of HPV-associated cancer. We just had less detection. We had shutdowns, we had lockdowns, people were social distancing. We just didn't detect as many cancers. So we expected to see a decline, and we did. And that decline was essentially across the board in 2020. So we expected an uptick. Well, in 2021, for both metro and non-metro urban, we see kind of just a stagnant trend, just right back to where we would have expected prior to the pandemic. Really just retaining the same levels as before. But we see a very concerning spike, about a 20%, almost a 20% increase from that 2020 year. of rural incidence of HPV-associated cancers. One of the things when you break this up by sex, it's even larger. The largest increase from 2020 and 2019 is found in female rural populations, where it's over 20% increase, kind of from pre-pandemic baseline. So a huge spike in HPV-associated cancer incidence. Unfortunately, this data is quite lagged. We don't have more recent data yet, but we're very concerned that this trend in the rural communities might be spiking, and it might continue to spike as we see flat or even possibly declining incidence from some of these urban areas that have had historically higher incidence of HPV vaccination rates 20 years ago. So this is quite concerning. And that really just leads to the rise that we're seeing in HPV-associated cancer mortality. Again, 20 years ago, this rate was the same across the board. Now we're starting to see a divergence between metro and non-metro. And I would predict, based on the increased incidence in rural compared to urban, that we're going to see this black line possibly shoot up in the next half decade. So just some concerning trends there, taking a real big picture view at only rural communities. Now, one of the things that we do is we spend a lot of time talking about rural versus urban, and it's important to give us context, but we also want to look, well, what's going on in rural communities? It's not a homogeneous set of people. There's differences across any type of socio-demographic factor that we want to consider. So let's take a deeper look there. And who bears the greatest burden if we kind of take an intersectional lens, sex, race, ethnicity, socioeconomic status, community resources, etc. Where is the HPV-associated cancer the highest in rural communities by some of these other factors? And we found some pretty interesting differences. I'm just going to run through a couple of slides here quickly, mostly to show you that there's no one group in every geographic area or every poverty status or race or ethnicity or sex that is consistently bearing a larger incidence of HPV-associated cancer. So in the Northeast United States, we see that American Indian Alaska Native males have significantly higher incidence of HPV-associated cancer compared to all other groups. And those people, especially for high poverty communities, high poverty neighborhoods. But we move to a different community. We go to the Midwest where I'm from, and we see it's different. Here we see that Black and Indigenous people of color who are female living in high poverty have a much higher incidence of HPV-associated cancers, likely cervical cancer in the Midwest. Moving again, there's really no group that's higher than the other here, just a very consistent pattern within the South, where regardless of race and essentially regardless of sex, people in high poverty areas in the Southeast United States have consistently high incidence of HPV-associated cancer. Much higher though in again, BIPOC females though living in the Southeast. And again, this is only rural. And then out west, rates are a little bit smaller across the board, but we see that, again, people who are American Indian Alaska Native living in high poverty areas having higher incidence of cervical cancer, and that's in the female group. So all that to say, and happy to share that data. Didn't want to dive too much into the details, but really just to show that there's no consistent pattern here. There's no one size fits all that if we target this specific community that we can make major changes across the board. It's actually going to have to be much more systematic, much more intentional and directed at the populations we're trying to serve with HPV cancer prevention and control across the United States. And with that, I just want to make a brief comment on health equity. I know that, again, most of the research I shared today was rural versus urban, comparing racial ethnic groups, comparing socioeconomic status. Great question, Rebecca. I can talk a little bit about that in a second. The equity framing of kind of us versus them, rich versus poor, I think that is it's been a disservice, and that's kind of a critique on my end in the research community, because there's a lot of lessons that we can learn from each other, a lot of lessons that maybe we can learn from females in high poverty areas in southeastern Iowa. Could we apply that, or how could we adapt that to communities in low poverty areas in the Pacific Northwest? So not only are we trying to move away from simply just rural versus urban, really trying to understand the broader implications and really think about that when we're communicating health equity topics, evidence and programs and effectiveness. And I just encourage, whether you have your own questions, what lessons can we share across geography and population? What focused, culturally competent and effective strategies can reduce the burden of HPV-associated cancer today? And how to eliminate rural inequities in HPV-associated cancer in the next generation? And Rebecca, you had a great question, since I've got about a minute here. It did look that most of the higher incidence groups were in high poverty areas, but that wasn't consistent across the board. For example, there was, I believe it was in the Pacific West, the incidence was higher for Asian Pacific Islander populations. It's actually higher in low poverty areas. And then if we kind of reverse the question, we'll say, well, where is incidence the lowest? Where is incidence the lowest? And then we start to see that, depending on sex, race, and ethnicity and geography, we see a lot of heterogeneity. In certain areas, you'll see that the burden of HPV-associated cancer is lower in high poverty areas. So again, certain themes might arise, but across the board, we can't really make any concrete generalizations. So, but great question. Yeah, and here's just a link to that paper if you want to dive in and look at some of the data. And I'm happy to answer questions afterwards. Thank you.
Well, thank you so much, Dr. Semprini and Athena, both of you, for being a part of today and for sharing such great information with us. We are going to do a brief Q&A with both of you, so please feel free to add questions into the chat. I know I've been looking, I don't see anything specifically in there, or you can raise your hand and we will definitely let you ask them live, but would love to just have a quick conversation with all of you. Imagining 10 years down the road, where do you see HPV vaccinations in rural communities? And I know you guys are coming from different perspectives, but I'll go with Dr. Semprini first and then Athena.
Yeah, I guess in the next 10 years, I unfortunately, and mostly speaking for Iowa, but I would imagine that these trends are pretty consistent across rural communities in the United States. But we're seeing a downtick, and we're seeing a divergence in rural HPV vaccination trends compared to some of the metropolitan areas. And we're definitely seeing we've always seen a gap for boys, young adolescent boys, compared to females in rural Iowa. And I am quite concerned over the next 10 years if that gap, we want to make things more equitable, and I think it's going to go in the opposite direction without some very concerted efforts in the next 10 years. Sorry to be so negative, but that's kind of what I'm seeing.
No, thank you. We appreciate it. Athena, what are your thoughts when you imagine what it might be, 10 years down the road?
Well, I'll try to take the optimistic view then. So I really hope that with the kind of backyard way that I'm trying to do is that hopefully within at least my area, by going into schools and talking and giving my story, that I do hope that within 10 years I see the HPV vaccine rate increase, and then hopefully just spread from there throughout Iowa and go from there. I know we've got a lot of work to do, but yeah, I'm gonna try to stay hopeful.
Perfect. Thank you. From both of your perspectives, I guess, what is one action our participants can take today to impact HPV vaccinations in rural communities? I'll start with Athena and then we'll go with Dr. Semprini.
Yeah, I think that just finding if there's some kind of unique way within just your community that can provide that education, similar to me going to the schools. I've found that there can be just unique ways, whether that's some kind of health fair or some kind of fundraising event that can just get people that information that's just so needed in a way that can hopefully they can retain and understand. Sometimes, especially when it comes to HPV, it can be so scary and the stigma and stuff. So just kind of trying to find a way within your own community that just works best.
Thank you. Dr. Semprini.
I saw a great question from Kat here, and I'm gonna just jump on that. So, given recent federal appointments and anti-vax trends, do you have any advice on how to talk about the importance of HPV vaccination without being shut down by rural community members? And I would say my response there is, you got to talk. We got to do our best to talk to these people, stepping kind of outside of our bubble, and also just how we talk to people. I saw a nice fact sheet going around at Iowa Public Health Association where we're changing the language that we're using. We're done with using the words misinformation. Most people in rural Iowa don't care. They don't know what that means. It doesn't have it doesn't resonate. It kind of sounds like you're talking down to them. There's a whole list of terms that really we invented in the academic community that have no business being used to change behavior. It's really just going to change people's behavior, that they're not going to listen to me or they're not going to trust me. So if you're working in that space, talking with, finding partners to help you better communicate with the folks in these rural communities. Great question, Kat.
That's a
Um,
really great
So
use.
I'll kind of hop in because I know there's one thing that a provider of ours does is in rural communities, especially if there's a lot of religious people that are have these young kids and they try to say like, well, my daughter is 9, she's not sexually active. I know a provider of ours tries to say, well, even if your daughter or your son, they say they wait until marriage and they go through all of that. There's no guarantee that their spouse had. And so this isn't about your daughter being promiscuous. It's not about that. And I think that has helped click with with some of the parents, not a lot, but some of the parents to be like, okay, so this is just protection against them someday. It has nothing to do with their actions right now, but it's just kind of a twist on like, well, think about it this way. And so it's been I think a different and good way for our providers to be able to talk to the patients in that way.
Perfect. Well, thank you both for participating in this Q&A and for being a part of today's session. We are going to transition to breakout sessions. So I'm going to have Hannah go ahead and pull up our slide. So we're going to go into breakouts for about 12 minutes and just have an opportunity to meet one another and talk through what we hope to learn during the series. There will be an ACS staff member in each of your rooms to help guide the conversation along, but I'm going to ask everyone to go round robin, just share a little bit about yourself, your name, your organization, your state, what you're hoping to learn, or some of your biggest goals from the series. And if we have extra time, because these breakouts will be a little bit bigger, talk about some of the current or past challenges that we've had within our clinic or our health system, improving HPV vaccination. So I'm going to go ahead and open. All right, well, welcome back, everyone. Thank you all for being a part of our breakout session and for having robust conversations and then just introducing yourselves. I hope you all got to meet some new folks and share some ideas amongst each other. So we're going to go ahead and wrap up today's session and do a quick poll and just share some resources to support your work and talk through next steps. So I'm going to go ahead and ask my colleague Tina if she could go ahead and pull up that poll for us. And so I'm just going to go ahead and give you a minute just to go ahead and share some of your thoughts. So we are finalizing our curriculum for this year and would love to know if you've ever participated in any of our American Cancer Society activities where we've talked about quality improvement tools and resources. Would love to know how many live sessions you plan to join, and then share with us, what format is most engaging to you. This will really help us to kind of finalize all of our topics for the rest of this year, as well as how we plan to share it out with the group. Looks like we've got some participation already, so thank you. %70 participation. I'm going to give it just another couple of seconds here. And for anyone that's having trouble with if you're still in annotation, if you just click out of the X box, it'll take it so that you don't have to play with the pens anymore. Perfect. All right. Looks like we are at 83% participation. I'll keep this open. And Hannah, if you want to go to the next slide for us. Perfect. So we shared during our 2024 sessions, but want to revisit with anyone that's new to the learning community. So we built an external facing website for all participants in the rural HPV vaccination learning community to be able to access all resources shared in 2024 and 2025. My colleague Tina is going to add a link to the chat for the website. So if you haven't done so already, I highly recommend that you, view it and bookmark it so that you can access it at any time. If you want to go to the next slide. So at the top of our website, you will have important links, and you'll see we've placed very important documents like our program overview, our registration. We've included both American Cancer Society and the National HPV Vaccination Roundtable's parent and patient-facing resources on HPV vaccinations right there. We also have recordings of all of our monthly sessions from 2024 as well. There will be monthly sessions for 2025. Just want to note that you can still get enduring CME and CNE for our August through December 2024 sessions. And we also have our resource roundup, which I'll talk about here in just a second. If you want to go to the next slide. As you scroll down the page, you'll find links to everything listed in the important documents section, as well as links to some clinical education materials, which houses upcoming webinars and CE opportunities for clinical staff, pharmacists, and even dental professionals. We've linked all of our quality improvement resources to help guide you through your HPV vaccination work. And lastly, we've included impact reports for American Cancer Society, the National HPV Vaccination Roundtable, and also our global HPV vaccination colleagues. Next slide. This slide just highlights some of the quality improvement resources that are shared on our website. We will reference these in the future, but wanted to know that you can access them now, and they can definitely help you if you are currently in your quality improvement journey or you are starting a quality improvement journey to increase HPV vaccinations. Next slide. This slide in particular shows our resource roundup, which is a comprehensive document that links references to materials and tools from previous sessions. This encompasses all of our sessions from 2024, and we are regularly updating this document. So you have a resource that you want us to share, please add it to the chat, or you can contact myself or Tina, and we will make sure to get it added in. We will be updating this with new materials throughout 2025. Next slide. So as always, we hope you are actively using this information shared during our monthly sessions. As a follow-up to today's discussion, we have some action steps for you. We encourage you to visit our website, check out the recordings from our 2024 sessions, and please, send out the training opportunities as well as the recordings to all of your colleagues in your greater network. In preparation for our next session in April, we're asking all participants to review the organization's prioritization of HPV vaccines, pull your HPV vaccination policy and procedures, find a way to look at baseline HPV vaccination data just to know where you're starting at. And it's also important to be able to pull other reports like missed opportunities so you know where there's gaps and opportunities as we prepare for that April meeting. Next slide. And I want to just wrap up and thank you for joining today's session. We look forward to seeing you on April 9th, where we will hear from Dr. Grace Ryan. We will be providing live CME and CNE credits for our April through December sessions. So we look forward to seeing you then. Thank you again.
Thank you.
Thank you.